This video has been funded by an educational grant from Biocon Biologics Limited. The European Alliance of Associations for Rheumatology, or EULAR, 2025 Congress was held in Barcelona, Spain, on June the 11th to 14th, 2025. The Congress welcomed more than 13,000 delegates and encompassed 177 scientific sessions and 1,505 posters. Dr. Laura Coates, NIHR clinician scientist and Senior Clinical Research Fellow at Nuffield Department of Orthopedics, Rheumatology and Musculoskeletal Sciences, or NDORMS, presented a session on the latest advances in treating psoriatic arthritis. We opened with a discussion about what personally attending the conference offers over remote participation.
Being there in person at the conference is an amazing opportunity to network and to hear research from different people. I particularly enjoy the poster tours and the poster discussions, because that's your chance to meet new people, to have really in-depth conversations and to find researchers who are doing similar research to you, and kind of throw around ideas or talk about collaborations, or if you're a clinician, to find research that matters to you in the clinic, that answers a question that you're not sure about, or provides data that might help you explain things to patients in clinic, or explain new treatments or different approaches.
Tell us about your presentation at this year's Congress.
So my invited session at EULAR was the How to Treat session on psoriatic arthritis, to provide an update for everyone on where the data are in terms of treatment and management of psoriatic arthritis and the things that we need to think about in clinic. There have been big changes, particularly in the last year, in early disease and treatment strategy trials, the first of which was presented at EULAR last year, some data at ACR this year, and more data kind of hot off the press actually at the EULAR conference. And then obviously the other changes are around access and availability of new therapies. So new therapies coming through to the clinic in the last few years, as well as some of the drugs that are currently in phase 2, phase 3 trials that will be coming to the clinic soon. So in terms of kind of the early strategy trials, there have been a number of studies looking at whether we should intervene more aggressively right from time of diagnosis. So if we give more intensive therapy early on in the disease, can we improve short-term and long-term outcomes for patients? Because typically we kind of go slowly and we trial cheaper, more conventional drugs first, then potentially combinations of them, and then on to biologics. So there are now 3 studies that have looked at early biologics, and also one looking at combination DMARDs as well, to give us an idea of whether this early intensive intervention can help. And I think across all of the studies, you see that more intensive therapy, particularly with biologics, gives you a very early advantage. So sort of 12 weeks, 3 months after starting treatment, those patients are doing better. If you look at the studies that took all PSA patients, by week 24, it sort of starts to lose the benefit, and actually even the conventional drugs catch up and do quite well. But if you take patients, as in the SPEED trial, where they had poor prognostic factors, they had more severe disease, there you see a better benefit at week 24 and even at week 48 for early intensive therapy. So we can see that what we need to do is personalised therapy more. Patients with mild disease, they're fine with methotrexate and stepping up slowly. Patients with more severe or poor prognostic disease, we should probably intervene more aggressively to get their disease under control quicker.
Is tailoring these treatments feasible in daily workflows?
Yeah, so I think it's not requiring anything too complex. It's just thinking about basic prognostic markers, like whether they have raised inflammatory markers, if they have obvious X-ray damage on the X-rays at presentation, if they're very highly impacted by the disease. So I think it's pretty straightforward to do, and it probably to some degree reflects what we do already. But the question is around access, and obviously that varies across the world. So early biologics in America, if you have good insurance, actually can already be done. Typically in Europe, you would have to go through a conventional drug first. And obviously there are many healthcare settings where access to biologics is not straightforward, but access to a combination DMARD, so using 2 cheap conventional drugs in combination rather than individually did also show a benefit. So I think there's something that different healthcare settings could do or look at doing in the future.
How have biosimilars facilitated access to those new generations of biologic therapies?
Yeah, absolutely. So access to biosimilars, I think, is key in terms of reducing the cost. So if we're thinking about the cost effectiveness of intervening early, actually having pretty cheap biosimilars available makes that a much more feasible option for different healthcare settings. So adalimumab is typically our first line drug across most of Europe. It's the most commonly used TNF inhibitor, and it's also the cheapest of the TNF biosimilars. So I think it's sort of become a standard drug. In the speed trial, that was with early adalimumab. So you could see that would be a cheap option to give somebody a short course of early adalimumab that potentially costs very little money, and then see if you can taper that and leave people on drugs like methotrexate in the longer term. I think now what we're looking at with newer therapies is often patients who failed adalimumab and where newer drugs fit after that kind of first line option.
What lessons from other disciplines could be applied to benefit arthritis patients?
We talked a little bit about kind of clinical personalizing treatment and using clinical markers to pick drugs. But obviously, oncology are miles ahead of us in rheumatology in terms of precision medicine. Everybody gets their tumour biopsied. You can look at what's important for that particular individual's tumour and then try and match the drug to the patient or the drug to the tumour. That's something that I think there's a lot of interest in rheumatology, but we're still miles away from that being routine practice. There's a lot of studies ongoing out there at the moment looking at whether either blood biomarkers or tissue biomarkers, so biopsying joints, which is obviously a bit more hassle than just taking a blood test, could be used in the future to guide treatment.
What other sessions from this year's meeting caught your attention?
One of the biggest topics in psoriatic arthritis was around difficult to treat disease, which obviously as a clinician is a real headache. So we can use adalimumab pretty easily after our conventional DMARDs. For people who respond well, that's straightforward. But we're increasingly seeing more and more patients who've failed multiple drugs and are struggling with active disease. So I think there are a few nice studies in that difficult to treat space. There was a bit more data on combination DMARDs, not always easy to do with combining biologics, usually because of cost restrictions, but some nice data looking at the effectiveness of that and thinking about controlling different aspects of the disease. And then with the kind of, we get a lot of patients who are difficult to treat or difficult to manage, maybe not because they have ongoing inflammation, but because there are ongoing symptoms. There was a really nice study in axial spondyloarthritis looking at providing a supportive app. So a patient's got an app that had advice on diet and exercise and lifestyle and help them kind of manage their disease and their lives day to day. And that showed a really excellent response in terms of AXPAR kind of outcome measures and quality of life and symptoms and pain. And having access to more supportive therapies beyond just the drugs, I think would be really helpful. The other thing that seemed to be a really hot topic at EULAR in general was thinking about cell therapies. That's something that's not really currently much of a plan in psoriatic arthritis. There's one potential target in axial spondyloarthritis, but in lupus and other conditions, we're seeing huge numbers of small studies looking at cell-based therapies. So bite therapies, other interventions that potentially just treat things in a very different way. And that's exciting because we've seen lots of, or an increasing number of biologics. Some of them work across different indications. So we're kind of sharing biologics with polymyalgia or giant cell arteritis that were initially approved in inflammatory arthritis. But having something that really works in a completely different way might hopefully provide a lot of hope for patients who don't respond well to the typical kind of immunomodulatory treatments.